Many emergency nurses have asked, what do we do when a patient with confirmed or suspected COVID-19 deteriorates in codes? How does our care change? How can we stay safe? Well, ENA has the answers for you. The American Heart Association has released new interim guidance for healthcare providers during COVID-19 outbreak. You can access this guidance through the AHA website or by going to the ENA COVID-19 webpage under Guidelines. AHA wants you to know that this guidance is intended specifically for when patients have known or suspected COVID-19. In all other cases, follow your standard protocols. Make sure to review the guidance in its entirety. Basically, AHA recommends following CDC guidelines on PPE during CPR and emergency cardiovascular care. Consistent with CDC guidelines, AHA states to use standards and transmission-based precautions during the care of patients with suspected or confirmed COVID-19. AHA considers CPR, endotracheal intubation, and invasive ventilation, aerosol-generating procedures. Aerosol-generating procedures may expose you to a greater risk of disease transmission, so AHA recommended that these procedures be performed in airborne infection isolation rooms by personnel wearing proper respiratory protection. AHA recommendations state to put on a respirator or face mask if a respirator is not available before entry into the patient room or care area. N95 respirators, or respirators that offer a higher level of protection, should be used instead of a face mask when performing or present for an aerosol-generating procedure. When the supply chain is restored, facilities with a respiratory protection program should return to use of respirators for patients with known or suspected COVID-19. Also, limit the number of providers present during the code procedure to only those essential for patient care and procedural support. In addition to respiratory protection, AHA recommends eye protection, gloves, and gowns. If there are shortages of gowns, they should be prioritized for aerosol-generating procedures, care activities where splashes and sprays are anticipated, and high-contact patient care activities that provide opportunities for transfer of pathogens to the hands and clothing of providers. If intubation is needed, use rapid sequencing intubation with appropriate PPE, and if possible, avoid procedures which generate aerosols like the big valve mask, nebulizers, and non-invasive positive pressure ventilation. Lastly, AHA suggests considering proceeding directly to endotracheal intubation in patients with acute respiratory failure. The use of high-flow nasal oxygenation and mask CPAP or BiPAP should be avoided due to greater risk of aerosol generation. Many EDs are also responsible for responding to codes outside of the department. Should you find yourself in a position where someone is unresponsive, and you are concerned that they may have respiratory symptoms, according to AHA, it is at your discretion to perform or not perform mouth-to-mouth breaths. However, hands-only CPR has been shown to be as effective as conventional CPR in many cases. It's still important to get additional help and find an AED. If you choose to perform breaths, you can also use a barrier device, such as a pocket mask or face shield, to help protect yourself. Hands-only CPR can be performed until you reach the ED or until help arrive. Hands-only CPR has been shown to be as effective as conventional CPR in many cases. If you choose to perform hands-only CPR, be sure to push hard and fast as instructed in your training. Overall, compressions with breaths is the most effective CPR in helping to save lives, especially in children, infants, and people whose hearts have stopped due to respiratory issues. But the most important thing is to do what is most comfortable for you. If you think the person may have been exposed to COVID-19, be sure to voice your concerns to your nursing manager or director of the potential for COVID-19 transmission. A lot of conversation is happening around advanced directives and end-of-life care. Many conversations are being driven by the realization that the risk to staff amid the dwindling reserves of PPE may be too great to justify the traditional response when a patient codes. Hospitals like Northwestern University in Chicago have been discussing a do not resuscitate policy for COVID-19 infected patients, regardless of the wishes of the patient or their families. This is a gut-wrenching decision to prioritize the lives of many over the life of one. It remains a major concern for many, and hospitals across the U.S. are admitting to similar conversations and looking for guidelines. Other hospitals have incorporated the use of a compression machine called the Lucas device to do chest compressions. This reduces the number of staff needing to respond in full PPE for a code situation. Others are draping the patient's chest and head in clear plastic sheeting prior to intubation and CPR to minimize the spread of aerosols, and then proceeding with chest compressions. Normally, nurses are bound by oath and hospital policies to use all available resources to save a patient's life unless a DNR is in place. Amid the national shortage of PPE and necessary life-saving equipment like ventilators, many hospitals are beginning to implement extreme emergency measures and establish policies for DNRs. Ultimately, the decision comes down to a hospital's resources, so each hospital must assess and evaluate their situation independently, as has been done in other countries facing this crisis. Resources used in the development of this audiocast include the American Heart Association, the Center for Disease Control and Prevention,